Degenerative disc disease, disc protrusion, disc herniation, disc sequestration. Degenerative disc disease refers to a group of conditions in which disc material is displaced into the spinal canal. The condition can be asymptomatic or manifest as radiculopathy due to compression of a spinal nerve root or myelopathy due to compression of the spinal cord. The site of nerve or cord compression can often be determined based on the patient's neurological deficits. Radiculopathy manifests with radicular pain, motor weakness, and loss of deep tendon reflexes in the dermatome and myotome territory of the compressed nerve root. Myelopathy is a medical emergency that typically manifests with motor weakness, sensory abnormalities, for example, saddle anesthesia, and bowel and/or bladder disturbances. Disc protrusion. Protrusion of the vertebral disc nucleus pulposus through the annulus fibrosus. Disc herniation, disc extrusion or disc prolapse, complete extrusion of the nucleus pulposus through a tear in the annulus fibrosus. Disc sequestration, extrusion of the nucleus pulposus and separation of a fragment of the disc. Disc protrusion, posterolateral disc herniation, central disc herniation, disc sequestration, annulus fibrosus, nucleus pulposus, spinal cord, spinal nerve. Epidemiology. It mostly occurs at 30 to 50 years of age. In males, it is more common than females. Disc herniation is the cause of back pain in roughly 5% of cases. Cervical and thoracic disc herniations are rare. Lumbosacral disc herniation. Most common site in lumbosacral disc herniation is L5S1. Second most common site is L4, L5. Pathophysiology: the intervertebral disc consists of a dense outer ring annulus fibrosus and a gelatinous core nucleus pulposus. These structures work together as a shock absorber by distributing high axial pressure evenly onto the cover plates and base units of the vertebral bodies. High pressure on the vertebral disc leads to fluid loss, and as a result, body height decreases physiologically by 1 to 2 cm during the day. Compression, tension, shear, and torque stresses on the spinal disc lead to degenerative changes that are dehydration and annular tear. This causes disc protrusion or herniation through the annulus fibrosus into the central canal, thus adjacent nerve root impingement, leading to sensory motor deficits in the affected nerve root. Posterolateral disc herniation or protrusion is common. It causes compression of the transverse nerve root, compressive radiculopathy. Central disc herniation or protrusion is less common. It causes compression of the spinal cord above L1 to L2 or cauda equina below L2, compressive myelopathy. Intervertebral discs usually protrude or herniate posterolaterally, as the posterior longitudinal ligament is thinner than the anterior longitudinal ligament. Degenerative disc disease. Central disc herniation. Central disc herniation will cause compressive myelopathy. Posterolateral disc herniation will compress nerve root, so compressive radiculopathy. Central disc herniation will compress spinal cord. Spurning maneuver, neck compression test. Apply downward pressure on the head. Extend and rotate the neck to the side of the pain. If limb pain or paresthesia is produced, then the test is positive and should be stopped. Production of neck pain alone in response to the Sperling maneuver is non-specific and constitutes a negative test. Sperling maneuver or neck compression test is indicated for cervical radiculopathy. Straight leg raise test. Straight leg raise test is indicated for lumbar radiculopathy. Straight leg raise produce pain in leg positive at 30 to 70 degrees. Straight leg raise stretches the sciatic nerve and its associated rami at roots at 30 to 7 degree of angle. Sciatic nerve, rami and roots will be irritated, thus there will be symptoms in the distribution of sciatic nerve. To test for malingering, leg is lowered slightly to point of no pain. Take extension of nerve. Then ankle is dorsiflexed. Restretches sciatic nerve and its associated rami and roots. Investigations. Initial investigation is X-ray APR lateral. Investigation of chest MRI without IV contrast. CT myelogram can be done if there are indications to MRI. This is normal disc, osteophyte or bone spur. Narrowed or thin disc is suggestive of disc herniation. X-ray of degenerative disc disease. Reduced disc height suggests disc herniation or prolapse. MRI disc herniation. These discs are blacker, these are dehydrated or desiccated discs. This white disc is not desiccated, this is normal. Disc herniation. Conservative management of degenerative disc disease. Physiotherapy with exercises to strengthen the back and neck. Continuation of daily activities. Improve backache. Minimize bed rest. Bed rest is only for severe cases of acute back pain. Analgesics, for example, NSAIDs. Oral glucocorticoids, though their efficacy is not proved. Epidural steroid injection. About 90% of lumbar disc herniations with acute radiculopathy start to improve within 6 weeks and resolve by 12 weeks with conservative management. Surgery. Surgical removal of the herniated portion of the intervertebral disc can be performed by an open approach, via minimally invasive surgery, microdiscectomy, or under fluoroscopic guidance, percutaneous discectomy. Disc herniation. Here, discectomy is done, partial disc is removed, and remaining disc is fixed. Spinal extension, that is bending backward, causes anterior bulging of the spinal disc, so there is no impingement of spinal nerves. Spinal flexion, that is bending forward, causes posterior bulging of the disc that causes impingement of the spinal nerve. Spinal flexion, bending forward, causes posterior bulging of the disc, thus impingement of the spinal nerves or spinal cord. Spinal extension, that is bending backward, causes anterior bulging of the nucleus pulposus or the disc, so there is no impingement of the spinal nerve or spinal cord. Thank you.